Hello students, today we'll discuss about the lateral chest x-ray. When we should take a lateral chest x-ray, what are the requisitions for lateral chest x-ray, and how to take a lateral chest x-ray, how does it appear, and how to read a lateral chest x-ray, what are the points used in assessing the lateral chest x-ray. First of all, we come to the question requisitions कि हमें किस पेशेंट पे करना है. Requisitions. First of all, if we have found an equivocal pathology on frontal chest x-ray. What does it mean? That we are not fully sure, it cannot be confirmed. Okay? We need one more view. We need to confirm that pathology we are suspecting on a frontal chest x-ray. Second one is to assess the hidden areas of frontal chest x-ray. What are these hidden areas? These are lung apex, around the hyla, third one is retrocardiac area, fourth one is below the horizons of diaphragm. ठीक है, we will assess the hidden areas on lateral chest x-ray whenever in doubt. First was to assess the equivocal pathology on a frontal chest x-ray. Second is assessing the hidden areas. Third is, if we have found the equivocal pathology, then we will characterize. We'll see where the pathology or abnormality is located. In the compartments, like in anterior, middle, or posterior. We'll come to the characterization part later on. Then we'll see how to take a lateral chest x-ray. We'll ask the patient to stand in front of the cassette and fold his or her arms above his head and will use the beam laterally from patient's one end to the other end. ठीक है? This is patient's left, this is patient's right. So this is a lateral projection. All of the points we should take care of, like we should do proper centering, like we do in frontal. Then how will a lateral chest x-ray appear? As we can see here, the vertebral bodies, as we move from upwards to downwards, vertebral bodies should appear darker as we move downwards. First of all, this. Then we come to diaphragms. As we know, left dome of diaphragm is not visible anteriorly. Why so? What is the reason for that? The reason for that is heart. Because the heart is situated and it is obliterating that border. Then we should see the scapulas overlying. This is the reason for opaque upper part. One is scapula, second is increased soft tissue at shoulder region. ठीक है? Then retro sternal lucency, we should look for should be seen retrocardiac area, it should also be properly assessed, and the hyla. Now we'll see the proper X-ray. As we can see, vertebral bodies are appearing darker as we are moving downwards. Then retrosternal lucency this is the right dome of diaphragm. Why so? Because it is present, it is seen throughout from anterior to posterior. Now this is the left dome of diaphragm. Okay. This region is the hilum. Basically both the hilas. This is the trachea here. Tracheal shadow. Now we'll see the points one by one. What are the checklist? How to read a lateral chest X-ray. Vertebral bodies, as I have pointed out, vertebral bodies, as we move downwards, vertebral bodies should become darker. This is the normal scenario. What is abnormal here? If not become darker, then we should suspect pathology in lower lung fields. And why should these vertebral bodies appear darker as we move downwards? Because there is left soft tissue as we move downwards. Next, we should compare both the domes of diaphragm, both the domes of diaphragm should be clearly visible and seen throughout. Right one should be seen throughout. Left one is seen only posteriorly. because anteriorly the heart is present. Then hyla. We should compare hilar shadows with the frontal projection. With the frontal projection. Why so? Because both of the hilum are overlapping here. Then we should see the cardiac shadow. We'll come to the cardiac shadow. This is the anterior border. It is formed by right ventricle. This is the posterior border, just above the, just behind the hilum. It is formed by left atrium. And this is the posterior border below the hilum. This is formed by the left ventricle. This is the cardiac cell out here, and how it is formed on lateral chest X-ray, and how we should assess that. Cardiac shadow. The cardiac shadow, all in all, the cardiac shadow should be visible, clearly visible to all of us. If not visible, if any of the heart border, first of all, we'll see the components of heart border. Anterior heart border is formed by right ventricle, whereas posterior border behind the hyla and below the hyla. Here it is formed by left atrium. Here it is formed by left ventricle. All of these borders should be clearly visible. What will happen if they'll be obliterated? ठीक है? If not clearly visible, meaning they are obliterated, then they'll suggest pathology involving adjacent lung fields. And at last, we should see of any abnormal density throughout the lateral chest X-ray. Like where? Any abnormal lung density like in retrosternal area, Normally it should be hyperlucent. Then we should carefully look for retrocardiac area. No abnormal or abrupt density change should be noted in cardiac oblique retrocardiac area. Otherwise, it will indicate any pathology overlying the area. At last, we'll come to the most important take home point from this class. Always interpret lateral chest X-ray along with frontal chest X-ray. The lateral chest X-ray is only a adjunct to frontal chest X-ray. Should never be commented upon individually. Now we'll come to few examples. As you all can see, we have only one dome of diaphragm here. This is the dome of diaphragm that is visible to us all the way. This would be the right diaphragm. We are not seeing any other part of the diaphragm, so we'll assume that the left dome of diaphragm is obscured. What will it give rise to? It will give rise to left lower lung consolidation. ठीक है? We'll come to the next. This is the right diaphragm, only seen anteriorly and not posteriorly. Hence, this is the right lower lung consolidation. Then there is the abrupt density change involving cardiac area. This opacification, this, I'll erase it. This is right middle lobe consolidation. These are all for now. Thanks for patient listening.